Assalamu alaikum. كل عام وانتم بخير. I'm so delighted today to resume our activity. This is the second Rheumatology Club meeting. It will be presented by Dr. Ghanem. He's a consultant rheumatology and head of rheumatology division. I would like to thank also the sponsor, abbvie, for continuous support for our educational Riyadh Journal Club meeting. So, Dr. Ghanem, yours.
Hi, good evening. Today we'll present a case that we have seen recently at our hospital. Dr. Abdurrahman Qasim, one of our residents, will present the case. After that, I will talk about the two major questions that was raised for this case, followed by a topic discussing the manifestation of this disease. Dr. Abdurrahman.
Assalamu alaikum. Good evening, doctors. Okay. It's not showing on the screen. Presentation. Yeah, this one. Yeah. So, how can we read it? It's very far away. Can you read it? Excellent. Okay, so this case is a 33 years old Filipino male diagnosed with SLE 4 years ago in our hospital. 4 years ago, he came to our ER with one history of generalized fatigue, mild gastric pain, lower limb swelling, and yellowish discoloration of the skin. At that time, he had high bilirubin and high amylase level. The total bilirubin was around 66. The direct was 44. Alkaline phosphatase was in the 700s. The ALT was 750, 75, and the AST was 61. Lipase was in the 1000, and also the amylase. So for that reason, he was admitted as under GS as a case of obstructive jaundice. On further workup in the patient, the patient did not have any biliary obstruction. MRCP done, and it did not show any obstruction, and there was no pancreatic mass. So normal information was provided from GS regarding his jaundice. Ascites was found, plus right pleural effusion was noted alongside a small pericardial effusion. He had a positive TAC test, and his hemoglobin was 7. Direct agglutinin test. His hemoglobin was 7.1, and the MCD was in the normal. In peripheral blood film, there was no schistocyte. The 24-hour urine collection revealed 6 gram proteinuria. He has a history of intermittent mouth ulcers, no genital ulcer with no rash or photosensitivity, mild joint pain involving his MCPs and BIPs, and wrists with no swelling, no Zika symptom, and no red eyes. He had mild shortness of breath, no cough or chest pain, no hematuria, no CNS symptoms, no history of muscle weakness or dysphagia, and no history of perictal bleeding. His complement at that time were low. His ANA was positive, antidepressant DNA was positive, anti-SNP was positive as well. The kidney biopsy showed the class 4 and class 5 lupus arthritis. On that basis, he was diagnosed as lupus SLE with lupus arthritis and started on MMF 3 grams per day by nephrology team. Tacrolimus was added by nephrology team after 1 year later to achieve complete remission. He maintained a low proteinuria level during that time throughout the 4 years. The latest was 270 milligram in January 2020, early this year. In July, however, after 7 months from He came with the 3 days history of abdominal pain and bloody diarrhea. The diarrhea was associated with intermittent fresh blood per rectum, very devastating for the patient. He was very anxious about it. History of nausea and vomiting, no history of eating from outside, and no fever. On examination, the patient was lying flat, not in distress. GBP was not visible, no lower lymphedema. The BB was in the lower side, 100/70, tachycardic a little bit, 111. His sucking blood normal, everybody. The abdomen was soft but tender, all over. No rebound tenderness or rigidity, and no organomegaly. The PR, it did not show any blood or melena. However, there was a yellowish aqueous stool. The other part of the physical examination was remarkable. His hemoglobin was 4, normal MCV, platelet was in the normal range, WBC was 3.1, polymorphs was 1.7, and 1.4 are lymphocytes. So, question 1.
Yeah, so the question to the audience is, what is the most likely cause of the patient bloody diarrhea? Is it CMV colitis, mesenteric vasculitis, medication side effect, colon or intestinal lymphoma? So we'll start the voting. Okay. Can we see the result?
Yes.
So, can I follow you? So, CMV colitis was the, okay. They can see the answer, the answers?
Yes.
Okay. So, colonoscopy was done. He was admitted again after GS, and colonoscopy, and he was stabilized, of course. Colonoscopy showed multiple ulcers. The largest was 1.5 centimeter from the rectum, and these ulcers are extended from the rectum to the ileocecal valve. Despite the stigmata of recent bleeding, there were no active bleeding. Biopsy taken from the right colon. The terminal ileum showed few ulcers, and biopsy was taken also. So the report, the histopath report. Why it's jumping like this? Anyway, the serology showed negatives for CMV, HSV, and HIV, and the terminal ileum biopsy showed moderate chronic inflammation with lymphatic hyperplasia, and also the same finding in the colon with lymphatic infiltrate. And the pathologist suggested that these features are suggestive of IBD, and he encouraged us to retake a biopsy from the left colon. So during that admission, the bleeding stopped. The patient was discharged from GS service with instruction on red flag and went to seek emergency medical service. He was seen by GI team with follow-up appointment, and the patient continued MMF and tacrolimus. He was discharged with MMF, tacrolimus, and hydroxychloroquine and prednisone 10 mg, and with furosemide. 2 months, that was in July. So 2 months later, he came again with PR bleeding. His CBC showed anemia, 6.5 hemoglobin, with normal MCV. Platelet was in the normal range, with the BBC was 4. His complement was normal as well, and there was some DNA was negative. So he also stabilized, received 2 unit back to RBC, and underwent a second colonoscopy. Again, multiple ulcer in the entire colon, sparing the rectum. Erythematous mucosa and multiple scattered abbvie in the rectum. The terminal ileum appeared normal. So, do you think they will vote on it or no?
Yes. Yeah.
Okay. Do you think the patient has IBD in addition to SLE? Yes or no? 50-50. Okay.
Wait for that. Wait a second.
Oh, yes.
Okay. So in full.
And for?
The majority said yes.
Yes, 77 and 4. Next. So the histopath, also again, the pathologist is insisting on the histopathology diagnosis of IBD. It showed some also infiltration in the lymphatic infiltration in the mucosa of the left ventricle. The terminal organ was in the normal, and the rectum also didn't show any ulcers.
Can we see the histopath?
Actually, I do not know how to manipulate this.
Unfortunately, that's on the slide.
Was there like a granuloma?
No granuloma. Absolutely, yes. Thank you for reminding me. Yes.
Was it like a transmural inflammation?
No. Just
only superficial.
Just superficial, but there was no crypt abscess. Mostly neutrophilic infiltrate. There was no. Sorry, not neutrophilic infiltrate. There was no. Suggesting a chronic inflammation rather than active acute.
And there was no cytopathic changes suggestive of colitis, like including body or enlarged nucleus.
And in the first presentation, no biopsy done at that time?
It was twice. It was done twice, and both times the histopathologist said that these changes are suggestive of IBD.
So, how would you manage this patient? You will force him to increase the result or BCMMF and Colonoscopy with anti-TNF. How can I start the voting?
So start the voting. Give them 15 seconds and then you can start in the phone.
Can we make it more interactive? Is it?
Yeah, sure.
Do you really think so? The question, actually, to answer this question, the question is: do you believe that do you know what's the ongoing? What's the diagnosis? Do you agree on the previous question that the patient has two conditions that are immunologically completely distinct? From your perspective.
Well, if I
and forget please about what the pathologist said, because at the end, it's your call, your shot.
If I answer you, it would be revealing, but there was a big reveal at the end. But let's discuss it for the sake of the argument.
I saw this patient. I believed it.
Okay.
It was ulcers from rectum to the ileum. Multiple ulcers. This is the first one. First colonoscopy, he had ulcers starting from the rectum to the ileum. The second colonoscopy is spared the ileum and spared the rectum. However, the pathology, yes, it wasn't specific. There was inflammation, no granuloma, but there was no other causes. No CMV, nothing suggests that this HSV infection or CMV infection. The serology were negative. We don't think it's vasculitis. He didn't have severe abdominal pain or rigidity. He wasn't sick. He was merely has this mild abdominal pain with fresh PR bleeding. So I thought that yes, maybe we have both. Maybe we have both. And we called the GI, which are the expert people, right? So initially they were suspicious about the diagnosis. They said maybe it could be that the patient has both. Okay. However, because the patient's symptoms improved, they did not start any IBD medication, and they say that the patient is already an immune suppressive treatment.
Can they get the discussion?
Okay. Yeah.
Can they get the discussion?
Steroid.
This is what we did.
First time given steroid. Also.
Yes, the first time given steroid, he improves. Initially, he was. This is the second. No. Initially, he wasn't given anything because it stopped right away by itself. The second time. So the first presentation with the patient
by itself because you gave him MMF plus.
He was already on MMF and tractolimus when the patient started to have GI bleeding, first GI bleeding. When he was admitted first, he was admitted by GS, and while he was inpatient, the bloody diarrhea and the fresh PR bleeding stopped twice. So he was seen by the GI. They thought that maybe it's IBD and SLE. But because the patient is already in immunosuppressive treatment, they say that the patient is already in immunosuppressive treatment, we don't need to add anything. So the second time, this is the second time when he presented, and we repeated again the colonoscopy. That the major difference between the first and second colonoscopy is that the first one had the patient had diffuse ulcers starting from the rectum to the ileum. The second, it spared the ileum and the rectum. However, he was having abdominal pain, fresh PR bleeding for second time. Yeah, and he was already
still, vasculitis we cannot rule it out. We need CT scan to.
Yes,
he had some, and you maybe I don't know.
Yeah.
But vasculitis is still in this patient with an active SLE.
Yes. This is the second time when he was admitted. We did CT abdomen and we did angiogram. It was unremarkable, apart from mild edema of the bowel walls. Okay, so there was no evidence of vasculitis according to the GI. The question is now he's already in immunosuppressive treatment. He's I think on 5 or 10 milligrams steroid. What should we do now? Should we give him pulse steroid? Should we increase the prednisolone from 5 or 10 milligram to 50? Or should we start him on IBD treatment or cyclophosphamide?
So the majority voted on A and B. A and B.
A and B, okay. So go, yeah.
And I take it for A as in lupus arthritis and B as an IBD.
Yes, as the question is now, will you treat him aggressively with the pulse steroid, or will you just?
What's in the pathology that is in favor of IBD and not lupus arthritis?
It was the inflammation. The inflammation, I think, and the macroscopic appearance that is suggestive of IBD.
But what if there was no specific findings? I mean, it would be quite difficult to distinguish the two.
Yeah, the problem that the lupus arthritis, as far as I remember, it usually doesn't present with ulcers, unless there is vasculitis and there is infarction or some or perforations. Most of the lupus arthritis, they either present as purely mesenteric vasculitis, or they have the diarrhea and edema, diffuse edema without causing ulcers.
I think we should agree that he has inflammatory colitis.
Yes.
And the second part, the etiology of the inflammatory colitis is not very clear. This is very important to keep in mind because immunologically, that both are completely, to major extent, very distinct. Where one has mainly T helper 1, T helper 2, antibody-mediated pathways in lupus, and in the second you have mostly T helper 1, T helper 17 pathway. So immunologically, to have both at the same time disturbed, very unusual.
Yes.
That's why I think it's fair to say that he has inflammatory colitis. Yes. And we are trying to treat the inflammatory colitis, and we are not convinced that he systemically otherwise has active lupus. I think.
I think that this is what the GI say. They said it could be. They were not sure because I said that the biopsy was not specific. There was not very long.
I missed the first part.
That's Colonoscopy.
Yeah,
for lupus arthritis.
It was started closely in close relationship to the ulcers department.
It was started. So he presented with the GI bleeding in 2020. He was diagnosed with lupus and lupus arthritis in 2016. 2016 he was an MMF. 2017 tacrolimus. Okay, so it's almost 4 and 3 years.
Just to follow up on your point, the first pathology report that the pathologist was inconclusive. He said this is inflammatory colitis. He didn't see anything about IBD. However, in the second report, he gained more confidence, and he said IBD. However, he did not mean toward either CD, Crohn's disease, or ulcerative colitis. He just gave it vaguely, undifferentiated colitis, most likely inflammatory bowel disease, and he did not lean toward any of the distinct pathology. However, the patient, we'll see it. So we increased the prednisolone to 50 at that admission. Once daily, he was on 5, and we increased it to 50, and he did not improve. So he still, the diarrhea, the body diarrhea is still going on. The GI team reviewed the patient again. So again, the question. Well,
what will you do now?
What do you want to do? Treat the patient with directly with anti-CMV, start pulse, DCMMF, and tacrolimus and subclinic, and and you keep in mind that the MMF and tacrolimus now going on for 4 years.
Dr. Rheumatic, is there any thing suggestive of post-transplant or post-inflammatory lymphoma or something such?
Yes, he didn't have, like by examination, he didn't have lymphadenopathy, no splenomegaly. He didn't have the B symptoms, the usual B symptoms like fever, night sweats. He was mainly having this mild gastric discomfort with pain, bloody diarrhea, and sometimes fresh PR bleeding.
So
the majority of the audience say that they will start anti-CMV medication.
So the GI team final impression, this is possibly related to MMF toxicity, and we held MMF, and patient was discharged home with a plan for repeat colonoscopy in 2 weeks.
Say that once we stopped the MMF, his bloody diarrhea stopped.
But he was on steroid, high dose.
He was high dose steroid, 50 milligram. He didn't improve with the blood.
Over how long?
I think for almost 6 days. 6 days. Once we admitted him, we said that okay, we should give him a high dose steroid. We increased it from 5 to 50. No improvement. We asked the GI team again to see him, and they reviewed it. They said that it's most likely it's MMF toxicity. So is it common to have diffuse ulcers involving the colon and the ileum secondary to MMF? The other question is vessel disease.
The third one is tacrolimus. I think
tacrolimus.
it's common to have tacrolimus.
And the combination.
Yeah. This is what they say. So we followed their recommendation. We stopped MMF. We said that he was supposed to have. You can continue.
So the patient did not have a repeat colonoscopy. He was supposed to have had last week. However, he was contacted 6 weeks after discharge. This was last week, and there was no more bloody diarrhea and no more fresh blood coming per rectum.
Yeah.
So we are scheduling this colonoscopy.
So he was supposed to be.
Next.
Okay. It's my turn. Okay. Thank you. So this is a summary of our case that we are trying now to answer this question. Does the patient have IBD, and is it common for inflammatory bowel disease to coexist with SLE? And the second question is whether MMF can cause colon and ileal ulcers. So to answer this question, this was a large study that was published in 2016. It's a case control study where they matched 5,000 patients with SLE with 25,000 age and sex matched healthy controls. As you can see, patients with SLE, they were more likely to have ulcerative colitis, 0.4% compared with 0.2% normal population, and Crohn's disease was 0.7% versus 0.3%. When we look at the patient with ulcerative colitis, patients with SLE, they were more likely to develop ulcerative colitis at later age. As you can see, the patient with age group 40 to 59 was 0.4% compared to 0.2% healthy population and 0.7% compared with 0.2%. And it was also more common in female compared to male. In patients who have SLE and Crohn's disease, there was no difference among the different age groups. It was high among young and elderly patients, and it was more common again in female compared with the male. When they did multivariate regression analysis, SLE was not significantly associated with ulcerative colitis. The p-value was about 0.052. However, SLE was more likely to be associated with Crohn's disease with odds ratio of 2.2 and significant p-value. However, there are some limitations of this study. As we know, this study was a registry, so they were not able to validate the diagnosis of SLE and IBD in these cases. In addition, it was represented a small population from a single geographic region. Other thing that we have to put in mind that these reports, the reports of SLE among patients with IBD can be confounded by the possibility of anti-TNF inducing lupus reaction. As we know that anti-TNF is the most common biologic medication that used as treatment for IBD, and it's difficult whether to know these lupus are drug-induced or primary lupus. To answer this question, also another study that was published by Germany group in 2011, where they looked at the frequency of ANA, antidouble-stranded DNA, and the lupus-like symptoms among patients receiving anti-TNF as a treatment of IBD. They included 180 patients, and the patients were either on infliximab, adalimumab, or infliximab and adalimumab consecutively. They looked at the rate of ANA, antidouble-stranded DNA, and the rate of lupus-like symptom development, and also they looked at the factor predicting the development of lupus-like symptoms. About 44% of patients had high ANA, 15% of the patient had high antidouble-stranded DNA, about 9% of the patient had lupus-like symptoms, and 1.1% has severe lupus-like symptoms. And they define severe lupus-like symptoms as a patient who required to stop the anti-TNF medication. When they look at the predicting factor for lupus-like symptoms, high antidouble-stranded DNA and age were associated with lupus-like symptoms, while using azathioprine or 6-mercaptopurine was protective against the development of lupus-like symptoms. There was no, in addition to causing lupus-like symptoms, age was also predictor for development of ANA, and immunosuppressive medication was also protective against the development of ANA. There was no differences between whether you use infliximab or ANA. You're more likely to have ANA, antidouble-stranded DNA, and lupus-like symptoms if you use one of these medications. Patients who have Crohn's disease were more likely to have high antidouble-stranded DNA compared with ulcerative colitis. There was no difference between patients with ulcerative colitis and Crohn's disease in regard to lupus-like symptoms or ANA. So the conclusion from this study is that patients who have IBD and receive anti-TNF and have high antidouble-stranded DNA, they're more likely to have lupus-like symptoms. IBD patients of higher age treated with anti-TNF antibody are at risk of developing ANA and lupus-like symptoms. Immunosuppressive therapy could be protective against the development of ANA and lupus-like symptoms. So the other question, can MMF induce GI ulcer? There are very few case reports of MMF inducing GI ulcers in lupus patients. Most of the literature review or the case reports were on patients who were on and had organ transplant and receiving MMF, and the majority of these patients actually developed mouth ulcers and not gastrointestinal ulcers. This is one of the case reports that I have found. It's an abstract published in 2007 in the American Journal of Gastroenterology. It was about 38-year-old female who had a class 4 and 5 lupus nephritis. She was initially treated with cyclophosphamide and then switched to MMF because of leukopenia. MMF was increased from 2 grams to 2.5 grams. And after that, she developed the diarrhea and the bloody diarrhea, and she required blood transfusion. Colonoscopy showed erythematous mucus and ulceration in the cecum because of the temporal association between the increase of the dose of the MMF and the event. MMF was discontinued and the GI bleeding resolved within 3 days. Colonoscopy was repeated after 4 weeks, and there was complete resolution of the ulcers. This is another case report of patient who had a living donor renal transplant. The patient was on MMF, and 2 years after starting MMF, the patient developed bloody diarrhea. He was treated blindly with anti-CMV agents. It was ineffective. GI toxicity of MMF was suspected, and MMF was switched to mesorbine. And after that, the symptoms improved significantly. 6 months later, colonoscopy was repeated, and there was no more ulcers. Again, this is a study we're looking at the oral ulcers in patients who had organ transplant. It included 9 patients. 1 of them were infant, and you can see some of the patients developed the symptoms after a few years. You can see very well here, but you can see that some of the patients developed within few days, and some of the patients developed the symptoms after 3 years. So it's not important. It's not usually associated with acute ulcers. So you can develop the ulcers later on. What could be the mechanism of MMF-induced ulcers? These are the hypotheses. Some say that it could be because of opportunistic infection. Some say that it could be because of direct cytotoxic and anti-proliferative effect of the mycophenolic acid, and some say that it could be both. Going back to our patient, did our case have IBD or MMF toxicity? IBD. The things that suggest IBD could be histopathology, although it was not specific. Also, we know that Crohn's disease could be higher among patients with lupus. What's against IBD is that the patient did not improve with the high-dose steroid, and the patient was already on immunosuppressive treatment. What suggests MMF toxicity, which I personally believe is MMF toxicity, is that the bloody diarrhea and fresh PR bleeding stop right away after we stop MMF. And also, when we contact the patient 6 weeks later, he did not have any more bloody diarrhea. However, he did not have a colonoscopy. We're waiting for him to have another colonoscopy. He missed the one that he was supposed to have 2 weeks after discharge from the hospital. What's against MMF toxicity is 4 years of treatment of MMF. However, as we say, from these literature review, you can develop MMF toxicity after a few years of treatment. So now I will go quickly over GI manifestation in SLE. The first person who published or documented the GI manifestation of SLE was William Osler. That was in 1985. He published 11 cases of SLE of GI manifestation. 3 of these patients had GI bleeding. As we know, GI manifestation is very common in patients with lupus. About 40% of patients with lupus have GI manifestation. Most commonly anorexia, nausea, and vomiting. Also, you can have dysphagia, abdominal pain, diarrhea, and hemorrhage. However, not all these symptoms attributed directly to lupus. It can be attributed to side effects of medication, infection, or intercurrent process. Prevalence of oral lesions in SLE varies widely. This is, unfortunately, the slide is not clear. You can see that the reported cases or the percentage can vary from 4% up to 53%. One of the reasons of this variation is, again, difference in difference in population. And again, the lesions in lupus has been classified broadly into either erythematous, discoid, or ulcerative types. In addition, other causes of oral ulcer could be attributed to Sjogren's syndrome, medication, or infection. Are oral ulcers painless or painful? I remember when I was a fellow and resident, they will always telling us that mouth ulcers in lupus are painless. And as you see here, there's one study that was published in 1970s, and at that time it documented that 82% of the ulcers are painless. However, further reports documented that painful mouth ulcers is more common. In a study published in 1984, about 57% of the oral ulcers are painful. And this could be secondary to the different type of oral ulcer that patient has. If patient has oral discoid lupus, it's usually painful. Other oral lesion could be painless. How can we know if the patient has mucocutaneous discoid lupus? By looking at the white spots within the ulcers. If you see white spot within the ulcer, this could be discoid lupus. Just a reminder that this oral discoid lupus can present while sparing the skin. So if you don't have a skin discoid lupus, it doesn't mean that you can't have oral discoid lupus. Esophageal involvement is also common in patients with SLE. I think we are used to ask about dysphagia, mainly in patients with scleroderma and mixed connective tissue disease, and we don't ask about with lupus, but it's common, and it could be secondary to the esophageal motility disorder in patients with lupus. Also, GERD, medication-induced esophagitis, and Candida esophagitis could be a cause of the esophageal symptoms. This is a study where they looked at 18 patients with SLE. They had esophageal symptoms, and 72% of the patients had abnormal manometry. They were having either hypotonia or rarely hypertonic changes at the lower esophageal sphincters. And this could be secondary to the inflammation reaction within the esophageal muscles or vasculitis or Bach fluxes. There was no correlation between disease clinical activity or disease duration. One of the things that I forgot to mention that oral ulcers, most of the study that looked at the oral ulcer, they did not find a correlation between lupus activity and oral ulcer. Although in SLEDAI, it's one of the measurements that we look for oral ulcers. And if you have flare and if you have lupus flare, high SLEDAI, and painful mouth ulcers, again, it could be discoid ulcers, not other types of mouth ulcers. Gastric involvement can be seen in lupus. It can be presented with epigastric pain, nausea, or asymptomatic until the gastrointestinal bleeding. And until now, we don't know whether SLE itself is a risk factor for peptic ulcer disease. Lupus arthritis is one of the also common. One of the let's say is not uncommon to see lupus arthritis in patients with lupus. And according to the Biologic disease activity index, lupus arthritis was defined as as either vasculitis or inflammation of the small bowels. And this should be supported by either imaging or biopsy finding. And the patient usually presented with abdominal pain, or you can find ascites by doing ultrasound or CT scan. Other symptoms include nausea, vomiting, diarrhea, or fever. Lupus arthritis usually occur at median age of 34. It happens about 3 years after diagnosis of SLE, and it's usually associated with lupus flare. And patient has high Biologic and high SLEDAI. And of interest, 65% of patients who have lupus arthritis, they also have lupus nephritis. Intestinal vasculitis, the prevalence again varies widely between 0.2 to 53%. But when you look deeply into these studies, patients who present with abdominal pain, acute abdominal pain, are more likely to have abdominal vasculitis. This is why you find here that 37% and 53% of patients would have intestinal vasculitis were mainly patients who have acute abdominal pain. And high antiphospholipid antibodies is a risk factor for intestinal vasculitis. This is what you can see in vasculitis. This is for the fellow. Mainly you see bowel edema. Sometimes you see what we call thumbprinting changes in either X-ray or in the CT scan. And in severe cases, you can see perforations and infarction. Intestinal pseudo-obstruction is a rare manifestation of lupus. I didn't see any case of intestinal pseudo-obstruction. It's usually present again with abdominal pain, bloating, and distension, and possible pathophysiology is either immunocomplex disposition in the smooth muscles or vasculitis affecting the smooth muscles or the nerve plexus. High-dose steroid alone or in combination with immunosuppressive agents are treated. Protein-losing enteropathy is also another rare manifestation of lupus. It's usually present with profound edema and hypoalbuminemia. Usually, the diagnosis by excluding other causes of low albumin like liver disease, nephrotic syndrome, and the treatment again includes steroid and immunosuppressive. At the end, this is our case. So we still. I still think it's MMF toxicity. Could the patient have IBD with SLA? It could be. We will see. The patient should have a repeated colonoscopy. Hopefully, he will have it soon within the next 2 weeks, and we will see if the ulcers were resolved or not. The message from this case is that Crohn's disease might be high in patients with SLA compared with general population. Also, we have to think of Mmf-induced toxicity in patients who present with mouth ulcers or gastrointestinal ulcers. Usually, these patients who have MMF toxicity, they usually don't respond to steroid, and the best treatment for this patient is to stop MMF and observe. Thank you. I don't know if there are questions from online or from the audience. Yeah.
What was the period between his first and second bleed?
So the first bleed was in July, where he was admitted under general surgery, and the second bleed was in October, when he was admitted under rheumatology. So about 3 months. Yes.
So if he comes
yes.
in a matter of a few weeks with a bleed, are you going to change your mind?
I would think as what you have said, it could be IBD, could be tachycardia, but I still think it's MMF, because once we stop the MMF, it's the bleeding stop. And we contacted the patient when I prepared the case. We contacted him last week and to ask him whether he had a scope, and we had bleeding. He said he doesn't have any GI manifestation, no abdominal pain, no PR bleeding. He's still in tachycardia. And I forgot to mention that his proteinuria increased when he was admitted. His proteinuria last time was about 1.3 grams, and he's supposed to have a repeated kidney biopsy. So he's waiting for a follow-up appointment with the GI for colonoscopy and kidney biopsy and for kidney biopsy. Question: if you present with the GI bleeding, next time I'll call the GI.
Dr. Ghanem, can you ask the attendees to write the question?
Yeah, if you have any question for the attendees, please write it in the chat group. Okay.
I think this is the one that, if you allow me to ask to comment, it's very small.
Yes, sure.
This is a wonderful case for so many reasons. The first part is it is very important, as we discussed earlier during the case, to question any presentation when things doesn't add up. That's a reminder for all of us, right?
Yes.
So his lupus is fine. He has still ulcers, so there is something wrong.
Yes.
That's number one. Number two, which I think is very, very important, I will be very careful to interpret studies like a case control when it comes to an increased risk for so many reasons. Well, first, you mentioned one is to make the certainty of the diagnosis.
Yes.
And you clearly saw in this particular case how the pathologist can be confused about an ulcer, and you truly believe that this is not an IBD. So in these spaces, we should be very careful. And the second part, the confidence interval in that study was
very wide. Yes, exactly. Yes, you're right.
Wasn't, and again, there are many limitations for this particular part. So we need to be very careful when it comes to this particular odds ratio. Third part, which I think very important, You noticed an improvement after you discontinued the MMF.
Yes.
Which is very important.
Yes.
But what is very important is to remember or to remind ourselves that this patient was in both MMF and tacrolimus.
Yes.
Now, there are drug interactions for both of them. There is an increased level for MMF and tacrolimus when they are taken
combined.
Yeah. So, yes, the patient did improve after we stopped one. It's very possible that that was toxicity related to either or because of the interactions.
Yeah.
And then the question, and this is very relevant in a context of proteinuria, because then your question would be, can I re-challenge the patient and put him back on cell-7, assuming that he responded back in previous time?
Yeah.
And in that case, I would suggest that we hold the tacrolimus and use the MMF. And of course, you will have your answer very shortly if you develop an ulcer again, because you know that the re-challenge induced the ulcer.
Yeah.
That's my
Thank you very much. Yes, I totally agree with you. I said that these studies, it was it was from a registry, and they were not sure whether the patient has lupus or has Crohn's disease. Maybe one of these patients had MMF-induced ulcer, and they documented as IBD, and we don't know. So I will go through some of the questions mentioned by the online group. What are the factors to potentiate MMF toxicity in patients with autoimmune rheumatic disease? As Dr. Abdulaziz said, that one of the things that we have looked about the interaction of the medication of MMF with other medications, and look if there are some medications that increase MMF toxicity. When I reviewed the literature, they didn't mention any risk factors of MMF toxicity. But as I mentioned, there were more case reports of MMF toxicity among organ transplant, documented among organ transplant patients. However, I can't say that organ transplant patients are more likely to have MMF toxicity compared with lupus because there is no head-to-head trials. Again, I forgot to mention when they did the biopsy for patients who have MMF toxicity in these case reports, they were not specific. The histopathologist couldn't say that this is by looking at the pathology that this is MMF toxicity. It was mainly by just stopping MMF and looking at the response of the patient. Is it important to advocate MMF therapeutic drug monitoring? I don't know if there is. I'm not aware that there are some blood levels that we do for MMF.
For tacrolimus.
We usually do for tacrolimus. There is, but I didn't do it. Actually, I'm not aware of that, and never ordered MMF toxicity. Yes.
Maybe not those related.
Exactly.
Yeah.
Yes.
But usually, if we combine both, we do a level for tacrolimus, and usually we take care that the level is not.
Yes, tacrolimus or cyclosporin. Yeah. So these are the questions. Thank you. Thank you very much.
Yes. Yes.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Dr. Al-Ghani for this excellent case presentation, very interactive. I wish that we have a fellow with us for to be more interactive. And this activity is mainly the Journal Club for the fellows. So we have all consultants, and they think the fellow with us as online, but we made it live because we need to resume our activity, discussion, and so on. So please, next time, all fellows should attend, and even our colleague, the consultant, for more interactive discussion. Now coming to the second part of this activity, which is we have a guest speaker with us from US. He's Dr. Michael Reilly. He's an executive director of Alliance for Safe Biological Medicine. Also, he was an associate deputy secretary at the US Department of Health and Human Service from 2005 to 2008. Also, he was responsible for policy development and implementation regulatory oversight for issue involving FDA regulation, and he's a senior advisor to the Assistant Secretary for Public Affairs and Assistant Secretary for Planning and Evaluation of Human Service for a few years. He's with us today discussing the safety of biosimilar as well as few points about or listen from European biosimilar market on biosimilar. So welcome, Prof. or Dr. Michael. So we can start. Sorry? Yeah, Dr. Michael, can you start? He's not here, his mic. Okay. You should start the presentation, but you have it registered, that's why. Okay. Maybe you will start.
There we go.
Yeah,
okay.
Yeah. Thank you.
Okay. I thought it was done before, but it was not. Hello. Thank you. Assalamu alaikum. My name is Philip Schneider. I will be presenting today rather than Michael Riley. And let me just give you a brief introduction of myself. I am the advisory board chair for the Alliance for Safe Biologic Medicines. Michael Riley is the executive director. And I'm a pharmacist by trade, and I've had some leadership experience in pharmacy organizations internationally as well as in the US. I also was a past president of the American Society of Parenteral and Enteral Nutrition, which is an interdisciplinary organization that's comprised of medical doctors, nurses, dietitians, and pharmacists. I also am a faculty appointment at the Ohio State University College of Pharmacy. ASBM is an organization that is focusing on the safe adoption and use of biosimilars. It was established 10 years ago, and supporting our efforts in doing this are patient organizations, healthcare professionals, researchers, and manufacturers. And those manufacturers are both those who make reference products or the innovator products and biosimilars. So it is a broad coalition of organizations and individuals who are interested in the use of biosimilars, but making sure that policies governing their use do not have a negative impact on both the effectiveness and safety of their use. I might call attention that the Coalition of State Rheumatology Organizations is a member of our organization. So rheumatologists are very interested in this because biologics are emerging as a very important part of the drug therapy that you can use to manage your patients. The Alliance for Safe Biologic Medicines was founded on 4 guiding principles. One is a focus on patient safety as being a priority when making treatment decisions. Secondly is learning from the experience that we gain when biosimilars and biologics become more widely used. Recognizing, since these are relatively new agents and we don't know as much as we need to know about the differences and similarities of these various biologics, that pharmacovigilance systems are really important, and promoting those is part of our guiding principles. And then finally, and we'll spend a fair amount of time talking about this, recognizing the fact that the physician has ultimate responsibility and accountability for the patients for whom they care. So keeping physicians relevant as policy decisions are made is a very important guiding principle for ASBM. In order to guide our work, we survey both physicians and pharmacists, and you can see from this slide that we have done surveys literally of thousands of practitioners, mostly physicians, in different parts of the world, in the US, Latin America, Canada, Europe, and Australia. And we'll be spending some more time talking about the data from the European survey because that's what prompted an interest in the presentation that I'm giving today. All of these surveys are available on our website if you're interested in taking a look at those. Something else that we do to inform our work is to meet with regulators, both regionally, such as in Australia, Canada, the US, and Europe, but also with the World Health Organization, particularly with the group that determines non-proprietary names. That's the International Non-Proprietary Naming Program at the World Health Organization. And we'll talk a little bit more about the importance of distinguishable non-proprietary names as it supports pharmacovigilance systems in a while, shortly. But we've met with all of these individuals to discuss regulations that are increasingly in place that affect not only biosimilars use, but also the physician and patient role in selecting them. So one of the things that's been acknowledged as people from around the world when we meet with these different regulators is the important role that Europe has played, because they have had the widest adoption of biosimilars historically. And the reason for that is, and I'm going to stop here for a minute. I've just received word that you would like to see me, and I don't know how to do that. Turn video on. There we go. Good. Hello. Assalamu alaikum again. Anyway, Europe is acknowledged as the leader of the approval and commercialization. And so they are looked on as a good example for those who are interested in speeding the adoption of biosimilars, particularly in terms of reducing healthcare costs, because these are very expensive drugs, as you well know. What we've decided to do is take a look at Europe. So one of the interesting things that we found is that while Europe was the leader and had 90% of the biosimilars market in between 2012 and 2016, the U.S. has begun to catch up and now has 50% of the biologic market. Now, that doesn't mean that they're using fewer biosimilars in Europe. The biosimilars are being used more in both the U.S., Europe, and in other countries as well. It's just that the U.S. is starting to generate greater use of biosimilars as well. And so one of the reasons for that are beyond the scope of this presentation, but we just recently published a white paper describing the U.S. experience with biosimilars market and some of the reasons why we think we're catching up to Europe in terms of our use in the U.S. compared to Europe. But the basis for this presentation was a white paper that we published earlier this year called Policy Recommendations for a Sustainable Biosimilars Market, Lessons from Europe. And this was authored by Michael Riley, who was originally planning to give this presentation, but also myself. So I feel comfortable giving a presentation and sharing our findings with you instead of him. So the goal of this paper was to look at different policy studies to identify principles that could be applied to developing a sustainable biosimilars market in other parts of the world. So obviously there's an interest in doing this. The way we were able to identify the characteristics in Europe that resulted in a successful market was a review of 5 previous studies and reports on the biosimilars market in Europe. And you can see those listed here. And those were studies that were done between 2014 and 2019 by a variety of different organizations, some of which were industry organizations and some of which were governmental organizations and payers. And so by reviewing these studies, we sought to identify common factors that were included in the findings of these studies that relate to the success in Europe. So one of the things that we included in this paper were what we consider the gold standard, 6 principles that are pretty common. Now, each of the various European countries is different and self-governed to some extent, but there is an effort to do some things commonly. So it's important to know that there are minor differences among the different European countries, but an attempt to create some harmony among them. And so the first of these principles is to encourage, incentivize, and reward innovation. And by that, I mean by avoiding discounting the acquisition costs to the point where there's no money available for a company to develop new innovative biologics, but also new biosimilars that create the kind of competition that people are looking for to reduce the cost of therapy with biologics. Secondly, because healthcare costs are high and there's an understandable need to look at ways to make the most responsible use of limited resources, we also have to take into account that when we spend money on healthcare, we're investing in the health of the people, and societal benefits derive from that. And so and biologics in all fields, including particularly the one that you're in rheumatology, have really revolutionized the care of these patients and provide substantial societal benefit. Thirdly is that procurement practices must provide for multiple suppliers. And again, there's a temptation to take a winner-takes-all approach and award a contract through the tendering process to one supplier. But that minimizes competition, but it also provides supply chain issues in case the manufacturer can't provide a sufficient amount of the product that happens to win the bid and to whom the tender is awarded. And also that if the tenders are awarded periodically, that they shouldn't result in a need to switch patients more often than every 12 months. So the general finding is these tenders are 12 months or longer. Fourthly, the physician autonomy to be able to choose the appropriate medicine for their patient is really critical. And if a switch is made for economic reason, that the physician is the one that makes that decision, not a third party. And also the patients are involved in saying that that's something to which they would agree. So the idea of automatically substituting a biosimilar for a reference product or among biosimilars simply because it's the cheapest drug without duly considering the clinical factors, effectiveness and safety, is something that is not done in Europe. The fifth is the the issue of pharmacovigilance, and since there are not currently differences in the non-proprietary names, in other words, what we would call the generic name in our country, that the brand name should be used in prescribing so that if an adverse event occurs or if a patient doesn't respond to therapy, there's a reduction in effectiveness, that the individual, when pharmacovigilance systems are structured, we know exactly what medicine that patient has received. So, for example, if there are multiple versions of infliximab, a reference product, and one or more biosimilars, and the patient doesn't respond or has an immune reaction or some other adverse event, it's important to know whether the patient received the reference product or the biosimilar, or which of the several biosimilars may be available. Now, this is where our discussions with the World Health Organization come in. We think that there should be distinguishable non-proprietary names. So in addition to the brand name, if a non-proprietary name is used in prescribing or documenting in the medical record or reporting an adverse drug event, we know exactly what medicine the patient received. And we think pharmacovigilance systems are important to increase confidence both among the prescribing community as well as among patients. And one of the keys to uptake of biosimilars is confidence in their use. And then finally, some countries have tried to develop strategies to encourage people to use less expensive drugs, including biosimilars, by either providing them a rebate or a gain sharing, in other words, sharing the savings that might result, or changing the compensation mechanism so that there's a financial incentive to prescribe a less expensive drug. And we think that's a conflict of interest that puts a physician in the awkward position of having to make a decision about personal financial gain versus the needs of their patients. So those policies are typically not in place in Europe, although they're discussed in many countries that are trying to increase the use of biosimilars. So we've concluded after the review of these studies, there are basically three principles that are important in establishing a sustainable biosimilars market. One is the physician should have the ability to choose what is in the best interest of their patient. Now, in Europe, there's a high degree of the use of biosimilars, so that doesn't mean that they're always prescribing the most expensive drug or the reference product. They're mindful of that, and they are aware of their need to contribute to making responsible use of the limited resources and managing costs. But at the same time, they have the responsibility to act in the best interest of their patient and based on scientific evidence and clinical experience. So again, the decision should rely on them, understanding that cost savings are an important part of their decision-making process. When government tenders are issued, they should be designed to include multiple vendors and should include factors beyond just the price. And some of those include the method by which the drug is administered to the patient, educational programming that's available for prescribers and patients, other services that are available, different dosage strengths that are available. And so, again, providing a broad, sufficient amount of products for you to use when the clinical situation justifies it. And ultimately, a level playing field among all participants is the best way to foster competition. So having mandatory discounts, which place artificial downward pressure on manufacturers, reduces competition in the marketplace because people choose not to enter it because there's not a sufficient return on investment for them to compete. And so they move on to other areas of therapeutics that ultimately short-term gains are outweighed by the long-term losses of having a sustainable market environment with good competition. So when we look back, we surveyed the European physicians again to find out what they think, in addition to the findings of the 5 studies that we reviewed. And this is a refresh of a survey that we did in 2013. And so we looked at different countries in Europe that are listed here, and they were drawn from practice areas that actually use biologics, and you see rheumatologists are listed on that list. And so we had even more responses on the 2019 survey, 579 than we had in the 2013 survey, and we found similar findings with the 2013 survey, but also some interesting shifts over the course of time. Now, we have presented these data at the last year's meeting of the European Society of Medical Oncology in Barcelona, and it was surprisingly, there was a lot of interest in the survey that we did. And one of the interesting findings that came up in the discussion about our paper was that over time, and comparing 2013 to 2019, familiarity and the comfort with biosimilars has increased among prescribers. They know about them, they're familiar with them, and they're more comfortable with them. But also, the importance of maintaining physician control has actually increased in addition to their increased comfort with that. So that was something that was viewed by the participants at this scientific meeting. Now, I'm going to go back. Now, I think we have a poll that I'm going to try to poll. Whoop, that's not the right one. Do we have a polling, or is that's not on my next slide because I didn't want to reveal the results. Well, if we can't use the poll, I'm going to go back to the slide. and just and you can compare the results of this to how you would have responded. Let's do it that way, and that way we'll stay on track here. We asked a few questions, two questions about the comfort level of using a biosimilar, both in treating a treatment-naive patient, in other words, for the first time, one that's never received that biologic before. But then the second question was, how comfortable are you in switching a stable patient, may have been stabilized on a reference product before the biosimilar was made available, to switch a patient from the reference product to a biosimilar. And so the strong majority of the physicians in Europe that were surveyed are comfortable prescribing to a treatment-naive patient. In other words, they understand the need to save money and to use a less expensive drug. And the risk of having a change in effectiveness is, obviously, since the patient wasn't receiving therapy before, would be difficult to measure, but they're comfortable using the biosimilar. On the other hand, changing a patient who's stabilized, sometimes it takes a long time to stabilize patients with inflammatory conditions, decreases to 60% when asked about switching a stable patient to a biosimilar. So it's a little different when we talk about a treatment-naive patient versus a patient who's stabilized. The second is the question of who should have the authority to make a decision about the choice of biologic that the patient receives. And as I mentioned before, this was something that was surprising when we presented it at ESMO. When asked how comfortable the prescriber is in having the sole authority to decide together with the patient the most suitable biologic medicine for the disease, the strong majority felt that it was either very important or critical for them to have that. And that was an increase from 72% in the previous survey in 2013. The next question we asked was if there is a situation where substitution is, and it could often is done by a pharmacist when the dose is prepared and provided to the patient. When that decision is not in the hands of the physician, but rather a policy requires the pharmacist isn't making this decision. The pharmacist is simply implementing a decision based on what the payer specifies, and usually that's based on the least expensive drug. Is it possible for the physician to override that by designating the biologic dispensation, the medicine that was prescribed be dispensed as written or not be substituted? And the strong majority of the physicians in Europe who prescribe biologics responded that they thought that this was either very important or critical. And this is, again, an increase over the responses in 2013. So physicians are becoming more concerned about their ability to be autonomous in making decisions that are in the best interest of their patients and being told what to do by non-clinical policies that require a decision or a use of a drug simply based on its price only. The next two questions we asked was, how comfortable are you in switching your patient to a biosimilar for non-medical reasons? And that is you as the physician. And then the second question was, how comfortable are you with a third party switching the patient? In other words, by health policy that's being done by a payer or the National Health Service, again, because of a tendering system that produces a lower price for a biosimilar and requiring that biosimilar with a lower price be used. And so the decision is non-medical, namely the cost issue is the only reason driving their decision about what medicine that patient can receive, as opposed to the clinical factors that a physician would take into account. And so more than half of the prescribers are uncomfortable switching their own patients themselves for non-medical reasons. And so this percentage increases to 73% when asked about third party initiating the substitution. So physicians don't like it in general, but if they can make that decision themselves, they're probably reluctant to do it, but there are much more objections to physicians being told what to do and not having the flexibility to make a decision based on what's appropriate for their patient. So if you're interested in seeing the full survey, that can be, again, is available at our website, and you can see that site here, www.safebiologic.org/surveys. So again, since European countries are all different, there are minor differences between policies that exist in Europe. But if we step back and look at, generally speaking, how biosimilars are switched in Europe, there are some common factors. One of the interesting things that's being done in the U.S. that is not being done in Europe, the U.S., the Food and Drug Administration in the United States requires, has developed a definition for a term called interchangeable biosimilars. And the FDA will consider a biosimilar to be interchangeable with a reference product or with another biosimilar if switching studies are done. And those switching studies involve treating patients with a biologic, another population with a biosimilar, switching them to back and forth. In other words, the reference product, the patient would be switched to a biosimilar and then back to the reference product. So those switching studies are required. And if the data suggests that or show that there's no clinical difference in both effectiveness and safety, then a biologic can be considered an interchangeable biologic, and that can happen at the pharmacy level without the pharmacist checking with the medical doctor before providing the drug to the patient. Now, there are requirements in most states in our country where the physician there needs to be a communication between the pharmacist and the physician, but that occurs after the fact. It's a communication rather than an authorization. That is not in place in Europe. So all biosimilars in Europe have the same non-proprietary name, biologics and biosimilars. They have different brand names, but they do not have any regulatory standard for what is or is not a biosimilar. So as a result, we have to rely on what studies are out there or what clinical experience exists with regards to switching between a reference product and a biosimilar or back. And there are limited data available, unfortunately, so we don't have the science to be able to guide our clinical decision making like we do with other clinical issues. There was a well-known study called the Norwich Study that was done in Norway, which is hence the name of the study, where they studied switching patients from infliximab, the reference product, to a biosimilar, and they found out in a limited number of patients there was no difference in effectiveness or safety, and so as a result, Norway has bid infliximab products out, and they select the cheapest product, and they've been able to achieve cost reductions of up to 80 to 85% as a result of that. However, the authors of this study stated that more studies are needed to examine multiple sequence switch as well as back and forth switches, and cautioned not to generalize their findings about infliximab to other biologic agents. So we have some emerging suggestion that there may be less differences than we fear, but right now we don't know that. And so as a result, the prudent thing to do in the clinical setting is to not substitute biologics, the reference product and the biosimilars, particularly in stabilized patients. So in Europe, this switching does occur in practice, but the decision to switch generally resides with the physician, and in consultation with the patient, not a payer or National Health Service obligation to switch. So as a result of this, we observed increased competition in the marketplace because multiple biologics are available and they compete with each other in the marketplace rather than just once a year with tender systems. So as a result, because of increased competition, the free market system usually results in competition for price, as other things as well, educational services, service from the company and so forth, and those types of things. But overall, the costs have reduced. There's been an increased consumption of biosimilars in the market, and so there's market access to different companies, so that's enhancing competition. And so because of the reduction in these costs, it's alleviated some of the budget pressures that exist with the use of these very expensive agents. But at the same time, reducing healthcare costs in the country so more people have access to these therapies, but also provides enough financial incentive to develop new treatment. The adoption of biosimilars with 90% market share and a few years back. There are minor differences. However, automatic substitution of biologics is forbidden. All approved biologics, originators and their biosimilars, are available on the market and reimbursed. Certainly, prescribers can be encouraged to use less expensive products, but when necessary, they have the ability to choose a product that's worked for their patient, particularly those who have been stabilized on therapies. Reimbursement decisions are independent from in other words, they don't create artificial financial incentives for prescribers to use a less expensive drug that might jeopardize their independent clinical decision making on what's most effective and safest for their patient. And interestingly enough, the time from approval of the product to first product sales for biosimilars is actually pretty short because of the competition that exists in the marketplace. These biosimilars get to the market more quickly, resulting in the kind of competition that is desirable in managing costs. So we think this is a good, there are good reasons for Europe to be viewed as a success and for lessons to be learned based on what's been done over there. But some are misunderstanding or misinterpreting the data. And one of the areas of our interest right now is Canada, because they are advocating a forced switching of patients from reference products to biosimilars to reduce the healthcare costs in Canada. The first of the 5 provinces in Canada that established this policy was British Columbia. Alberta is in the process of considering this as well. And so there are numerous patients that are on biologic therapies, including rheumatoid patients, patients with rheumatic disease, that are being forced to switch from whatever product they've received and have been treated with successfully to one that is less expensive and without regard to the medical need. So many patient and physician organizations have risen up to object to this because they think it overrides their independence and autonomy in making patient care decisions that are in the best interest of their patients. And that's something that they're accountable to do. And patients trust their medical doctors to treat them effectively and to do so with being mindful of cost, but at the same time being most concerned about whether the medicine works and whether it's safe for them to use. And so we see in Canada, the gastroenterology organization and patients that have gastroenterologic conditions have had opposition to this. And we've seen in other countries, in Australia, for example, the rheumatologists and rheumatology patients have raised, when this subject comes up, objections to the government considering this forced switching policy. Now, if we look at the rationale and what's being cited as the reason they're doing that is that the statement by the Minister of Health in Canada said that in British Columbia said, we are behind Europe, and so we need to catch up, and so we need to do what they're doing in Europe. And so, of course, they are behind in Canada because they don't have a substantial biosimilars uptake there, but they're misinterpreting the fact that this forced switching is the way Europe has been so successful in improving the use of biosimilars. And so here's an example that was used, and a statement from the gastroenterologist and the patient organization in Canada raised several points, and it's recognized the need to manage costs. It understands that, so they're not just do whatever I want because I'm in charge, but at the same time, don't undermine my responsibility for taking care of my patients. And so here's some the recommendations that were included in one of those joint statements from the physician and patient groups. Patients may be started on a biosimilar if they've had active disease and have not been exposed to biologic previously. In other words, a treatment-naive patient. This is with the understanding, though, that there is drug cost savings to the payer, and that they're significant enough to do that. Secondly, non-medical switching for patients who are stable on biologics treatment is not recommended, and automatic substitution without regard to the physician or patient choice is not recommended either. So, fortunately in Alberta, because of COVID-19, this was the policy of forced switching that was implemented in British Columbia has been paused based on COVID. So we're in an active process of trying to educate the patient, physicians, and policymakers and patients about the true lessons that we've learned from Europe and the information that I've shared with you today. And so this information is available on a educational website, noforceswitching.ca. And so we're trying to educate people about the true scope of the strategies that were successful in Europe. So what are the lessons that we can learn from Europe? Again, to review what I presented previously, the 6 principles of gold standard. Policies that are developed in the name of trying to manage costs, which is a very important thing. We recognize that, but they should provide enough room to create incentives for people to enter the market, and also to develop new innovative therapies that are increasingly possible. Secondly, as we look at the high cost of biologics, the value that they bring to the marketplace needs to be acknowledged. Better healthcare does have a cost. Treatment decisions should be made by the physician for their patients, and if policy decisions that potentially affect this are developed, both physicians and patients should be involved in the decision as to what biologic the patient is permitted to receive. Fifth, strong pharmacovigilance systems need to be in place, and depending on where you are, and until non-proprietary, distinguishable non-proprietary names are in place, using a brand name to prescribe so we know exactly what medicine the patient received when the therapies are documented and adverse events reported is really important to strengthen the impact of competition in an open market. Ultimately sacrifices long-term sustainability over short-term gains. The 3 must-haves that we discussed earlier, the physician should have the freedom to choose therapies that are most likely to benefit their patient based on the science and their own clinical experience. When tenders are written, they should include selection criteria beyond just price. Some examples might include education, service, available dosage strengths, patient-focused choices, and a steady supply chain. And then finally, maintaining a level playing field is important so that all participants can participate in a competitive market that fosters both lower prices and innovation and results in a sustainable future for biologic therapies. So with that, I will conclude, and I'll be happy to answer any questions that you may have. Shukran. As you're thinking, I might add, it's a shame that I can't be back in the kingdom. I've been there twice, once as a visiting professor at the King Faisal Hospital. I was in Riyadh for a week, and then for a nutrition meeting in Al Khobar, had an opportunity to visit there as well, and so enjoyed my trips to the kingdom greatly. Would like to have the opportunity.
Thanks a lot for sharing with us the experience of European, and this is now open for question. So kindly, for the attendees, kindly type your question at the question and answer. So can you open the question? Can you close sharing so we can see the question and answer, please? Can you close sharing?
Let's see. Chat. Here we go. I see a chat.
Yeah, till we have the question, I can see it. So this is what is going on in Europe and in Canada. So can you share with us the experience in US? How you start switching medical and non-medical switch? Any policy? Because we have just seen in the ACR about the guideline for management of rheumatoid arthritis, and in the new guideline there is nothing indicating biosimilar, when to use, and they put it in the same level of the originator. In Saudi Arabia, so far we have only infliximab. We have it like for the last 4 years. And when we started having this biosimilar, the infliximab, it was in our pharmacy with the same name. So we are using infliximab and we don't know that it is biosimilar. But now the states change and there is some regulation and there is some advice that it should be with the biosimilar should be with names. So we don't use the same brand name. So biosimilar as well as the originator should be different. So when the physician prescribe, he should know that he is prescribing. Usually we prescribe just say infliximab, but now we have to write whether it is the originator or the biosimilar. So what about in US? Any regulation?
In the are you asking what is the experience in the U.S.?
Yeah.
Yes. Well, the experience is that in our country is a little bit unique in that we have employers hire pharmacy benefit managers who have negotiate prices for different all the drugs basically, including biologics, and they the pharmacy benefit managers receive a payment, what's called a rebate, if they can convince enough prescribers to prescribe a specific product from a specific company. So that company pays the pharmacy benefit manager for what we call moving market share. And so one of the debates in our country right now is they shift the costs to the patient so that it's so expensive. It's the patient will say, I can't afford these medicines. And so so there's a debate between pharmacists and physicians and these pharmacy benefit managers is whether they should be allowed to do that. And the reason this is a conflict of interest is that these pharmacy benefit managers don't have any responsibility for the patient. And so to put the burden of sharing the cost for these very expensive patient therapies on the patient simply to save money for the employer or their publicly held companies are actually shareholders that can benefit from this has created a conflict in our country. So our states are trying to regulate pharmacy benefit managers, and our Supreme Court is considering a case that will allow them to do that. But in the meantime, any biologic is available for the patient, but there are some financial considerations that are being imposed upon patients in particular for the use of these by companies that manage pharmacy benefit plans. So it's an evolving situation. And in the meantime, what we're starting to see is biosimilars are having an impact on reducing costs. And so if we can get this conflict of interest rebate system resolved, we think that the competition is going to reduce the cost of biologic therapies on their own based on the market systems.
Yeah, great.
It's a complicated world of the U.S., and that's as simple an answer as I can give.
I think in the future we'll end with the price, which is more or less similar between biosimilar and the originator, because some of the originators, like Cimzia and so on, or the other, they are starting reducing the price to nearly similar to the biosimilar price. So maybe in the future, we don't know, we'll have great reduction even in biosimilar, because the original price of the biosimilar wasn't that low. So it was just like 20% below the originator. And nowadays, it seems to be there will be further reduction. And this is for the benefit of the patient. And, okay. Okay, thanks a lot. It seems to be there is no more question from the audience. Thank you for your time. I know that I think you have a very early morning or what? The time?
Say that again.
We are now at 9 o'clock p.m. and I think you are early morning in US.
I'm in Ohio right now, which is it's 1:15 or 13:15 if you're using a 24-hour clock here. So it's a nice time of the day here, but I know it's late for you.
That's good for us. Anyhow, thanks a lot for your discussion. Thank you for the audience. Thank you again for everybody. Thank you for abbvie for sponsoring this meeting and wishing seeing you, inshallah, next month for in our journal club. Thanks a lot. Bye.
Okay, shukran.
Have a good night. Have a good night. Yeah. And for us, we go to dinner. So we wish so we are inviting you to take a dinner with us.
Dinner or to sleep?
Go and sleep. Yeah. Bye. Thank you.
Okay. Bye-bye.
ممتاز ممتاز بس بغى لما بدري لما يجي على اساس يكون بدري ابغى التسجيل حد انت بالتسجيل لا تقول هو ريكورد دائما يسالهم هو ريكورد طيب يعني حتى لو
اخرنا